This module will teach the proper technique and clinical relevance of orthostatic vital signs. Symptoms that are most commonly associated with orthostatic hypotension are dizziness, lightheadedness, and fainting, also referred to as syncope. Orthostatic hypotension occurs in a variety of clinical settings. Obtaining accurate values may have a significant impact on patient care. Because clinicians base their management strategy on the results, accuracy is essential. At the end of this learning module, you will be able to describe the proper technique to perform orthostatic vital sign readings. You will correctly interpret the results, and you will list 3 common causes of orthostatic hypotension. A common complaint elicited in the outpatient setting is acute dizziness or lightheadedness, which is frequently associated with an acute illness such as viral gastroenteritis, leading to vomiting and diarrhea and dehydration. In the emergency department and in the inpatient setting, acute kidney injury is commonly encountered. In all of these acute settings, one of the most valuable assessments is orthostatic vital signs to help determine the patient's volume status. Performing orthostatic vital signs will be demonstrated in a video later in this learning module. Have the patient lie in bed with the head flat for 5 minutes. Measure the blood pressure and the pulse while the patient is supine. Instruct the patient to sit. Ask the patient about dizziness, weakness, or visual changes associated with the position change. Note sweating or paleness. Check the sitting blood pressure and pulse after 3 minutes. If the patient has symptoms associated with this position change, or if the sitting blood pressure is less than 90/60, stop the test. Ask the patient to stand. Ask again about dizziness, weakness, or visual changes associated with this position change. Note sweating or paleness. The patient should be permitted to resume a lying position immediately if they feel weak, as if they're going to faint. If not, measure the patient's blood pressure and pulse immediately after the patient has stood up, and then repeat the measurement 3 minutes after the patient stands. Support the forearm at the heart level when taking the blood pressure. Assist the patient back to bed. When compared to a supine blood pressure measurement, a fall in systolic blood pressure of greater than 20 millimeters of mercury, or a diastolic blood pressure fall of greater than 10 millimeters of mercury, or a rise in pulse of greater than 30 beats per minute after 3 minutes of standing is abnormal. A persistent decline past 5 minutes suggests a more significant abnormality. This is more commonly seen in a neurocardiogenic disorder, which is typically chronic. A blood pressure drop immediately after standing that resolves by 3 minutes does not indicate orthostatic hypotension. However, this finding may be useful to confirm a patient's complaint of feeling dizzy upon standing and may lead to a need to review the patient's medications and to educate the patient about taking caution when rising from a lying or sitting position. A clinical example of the importance of performing this test correctly is when a patient presents with acute kidney injury in the setting of chronic kidney disease and/or chronic heart failure. We want to know if the acute kidney injury is related to too much diuretic use causing dehydration, or to the complex condition of cardiorenal syndrome. If the orthostatic vital signs are normal, then this most likely represents cardiorenal syndrome and not dehydration. This can completely change our management strategy. In summary, we reviewed the importance of obtaining accurate orthostatic vital signs. We identified the objectives of the entire learning module. We discussed some causes of abnormal orthostatic vital signs. We reviewed the technique to obtain orthostatic vital signs, and we showed how to interpret the vital sign values that you obtained. Please move on to the next part of the module.